Good morning, everyone. And one, I do thank you all for so far attending our sickle cell satellite session. And for many who have attended conferences, we do understand that it can be a little interesting, and we always have to be a little flexible in our agenda. One of our next speakers actually did not land until 9 o'clock this morning. And the fact that, one, we would love to hear a presentation. She wasn't able to be part of the 8 a.m. session, and so we are going to have Dr. Alexis Thompson come in and do her presentation now. And because I did not have her bio at the time of the schedule change, we're going to have her assistant, Ms. Lee, come introduce Dr. Thompson for the next presentation. And then we will continue with the program with Sickle Cell Panel Discussion 3 following Dr. Thompson. Thank you.
Good morning. My name is Tasha Lee, and I'm manager of sickle cell disease policy and programs at the American Society of Hematology, ASH, as we so lovingly call it. I have the pleasure of introducing Dr. Thompson, Dr. Alexis Thompson, who is currently the hematology section head at Lurie Children's Hospital in Chicago. She holds a Watson and Sarah Armour Endowed Chair for Blood Diseases and Cancer at Lurie Children's. And she is also the professor of pediatrics at Northwestern University Feinberg School of Medicine. Her clinical interests include hemoglobinopathies, including thalassemia and sickle cell disease, bone marrow failure syndromes, and stem cell transplantation in pediatric patients. Her current position is an investigator in a number of multi-center trials, as well as her own institutional clinical trials on thalassemia, sickle cell disease, and ITP. Her most significant contributions are in clinical and translational studies to better understand and treat hemoglobinopathies, and she is a leader in a number of multi-center collaborations, such as being the independent chair of the recently funded NHLBI Sickle Cell Implementation Program. She has served on a number of regional and national advisory committees for governmental agencies as well as nonprofits, and I'm proud to say she is currently president-elect of ASH. Dr. Thompson.
Good morning. I feel like in some ways I may be preaching to the choir, but this certainly seems like a friendly crowd. It's great to see several old friends and new friends in the room. What I'm going to do is I'm going to walk you through fairly quickly, again, to keep us on time, of some of the current initiatives and some of the recent ones that we've completed as part of the American Society of Hematology. I think most in the room may be familiar with ASH, but for those who are not, ASH is an organization with 17,000 members in almost 100 countries, and that we are dedicated to, this is the largest professional society that looks at blood diseases and their treatment and cause. And as part of that, there are both clinicians who treat patients with sickle cell disease and scientists who are interested in investigating the causes and potential treatments. I don't think I have to tell many that, where we stand right now. But from our perspective, there certainly has been progress, I think it's safe to say, across the lifespan. Progress, there remain to be challenges, but many of those challenges, in our view, also represent opportunities. The greatest progress, without question, has been newborn screening. And then because what it has done is it allowed us now to actually use evidence-based interventions that save lives and prevent complications in children. The challenges are that there's actually very limited data to actually inform whether or not children are truly benefiting from that. I cannot tell you, for instance, even though we've known now for 30 years that penicillin prophylaxis saves lives, I cannot tell you how many 3-year-olds take penicillin. I cannot tell you how many of them are fully vaccinated. Fundamental things that will tell us quite a bit about the health status of these children. Hydroxyurea, which is currently still not FDA approved in children, but is approved in adults. There's a number of fantastic studies that have been completed showing its benefits in both children and adults, yet it's underutilized. Opportunities really are there for us to take advantage of the fact that we think, almost 100% of children now in the United States. Yet there are opportunities to follow them and to understand more about this disease. Similarly, we think that once we can do that, we will ensure access to high-quality, evidence-based medical care, and also making sure, that, as was already discussed in an earlier session, the opportunity for families to consider participating in either clinical trials or having access to disease-modifying interventions. In terms of adults, we are very proud in this country to now acknowledge that this is no longer a pediatric illness, that well over 95% of children born today in this country will survive to adulthood. That is in contrast to less than 10% of children who are born today in sub-Saharan Africa that will survive to their 5th birthday. Having said that, there are challenges. There's an amazingly increase in healthcare utilization. Sadly, it occurs the greatest demand seems to be between people who are 18 to 30 years of age. I think many of us think that there is something physiologic about this increased demand. It also happens to be when these individuals are in transitions from pediatric to adult care, and when many of them have less stability socially and certainly with insurance. Hydroxyurea, again, is FDA approved, but we think is underutilized. And I think that we have to acknowledge that there really is a paucity of knowledgeable providers for sickle cell, not just hematologists, but all providers. There are some opportunities. The NHLBI guidelines that are evidence-based management came out almost 3 years ago. Certainly is an opportunity. And then I want to describe to you some of the ASH research priorities, which we think also are giving us some information about a way forward. Additional issues, again, I'm preaching to the choir. Only a minority of sickle cell patients, we believe, are receiving care in comprehensive centers, many of which are in urban centers, many of which are associated with academic medical centers. And the quality of care, the quantity of care that's available to the vast majority of sickle cell patients is largely unknown, but there's good reason to believe, based on the data that's available, is that it is inadequate and that it is not at the standard that it could be. We know that there are there's limited coordination of community services. Some of the things that Mary talked about at her center are fabulous, but I will tell you that I don't have such capacity in Chicago. And one area that I think all of us are struggling with is the limitations in mental health services. And also, not surprisingly, there's an increased rate when adults are asked in their dissatisfaction with their care. ASH has been involved actually in this sphere for some time. So I certainly taking a step back, as many who are ASH members can well attest to. ASH is relatively agnostic as a general rule when it comes to conditions. That by and large, blood disorders is a wide array of both malignant and non-malignant conditions. However, there is no question at all from an internal perspective that sickle cell disease fundamentally is a blood disorder, and that really in more recent years, ASH has really pivoted to really take a strong focus on sickle cell disease. But we began in 2007 with a workshop to help us understand what some of the priorities are. We had a number of partners who joined us right around 2010, 2011, when the community was rocked by the questions about sickle cell trait and risk of dying from athletic participation. And ASH took a lead in that, again, because this is our professional society, to really oppose that, because we think that this, at that time and even currently, is not scientifically based. We've had a number of briefings on Capitol Hill and have established a set of research priorities, not only for our members, some of whom are research investigators, but also hopefully for federal partners, for other people who are in partnership with us, to understand what at least those of us who are specialists in this area believe should be the research priorities. In 2015, we had a call to action summit that brought together about 100 people representing a wide variety of constituents, to begin asking the question, what needs to be done and what can be done collectively? And this has led to the development of the Sickle Cell Coalition, which I will share with you, as well as our sickle cells, the state of sickle cell, and our call to action. These are a number of them. I certainly am not going to go through all of these by any means, but these are a number of the recent efforts that ASH is undertaking in sickle cell disease. We have a sickle cell disease task force, which initially was a part of governmental affairs and was really sort of focused on, legislative issues. We now see how important that is to our entire organization, and so the task force actually reports directly to the executive committee and allows us to actually have individuals who are overseeing all of the programs within ASH. I'll share with you some of ASH's research priorities because we certainly think those are important to continue to keep them updated. The NHLBI guidelines was quite a document, but we realized that it needed to be converted into something that was far more workable. And so you'll see at the top, there's a picture of 3 pamphlets, which is, of course, the way people in my generation who wear white coats, we'd put one of those in our pockets. We know most of our younger trainees and colleagues actually use things on their cell phone, and so they're now readily available as an app on mobile phones. We have our policy strategy, which is online primarily for sickle cell trait. We've established the coalition again, which I'll talk about, the call to action, and then some awareness materials, which we were very proud to collaborate with the Sickle Cell Disease Association and the CDC. The one that's actually shown here is one of them that actually is giving us materials to provide to coaches, to athletes, to trainers, to physicians that are responders about how to address what concerns there may be about athletic participation. But then there are also a number of other conditions that require. I mean, I think the one that most people struggle with is sickle cell trait and A1C testing for diabetes, just reminding ourselves that there really are some areas that really need more awareness. In terms of our priorities, these are available in much more detail on our ASH website, but these are certain areas that we think that if we can start making headway in some of these, we really do have an opportunity to look for more ways to treat patients. First and foremost is predicting the severity of this disease, which right now is quite broad. There will be some children who are born today that really will have minimal complications, yet there are some individuals who have complication after complication after complication. What makes them different? It seems to us that in this day, with the genetic tools that we have, that we could really make headway in understanding the severity, which would allow us to apply higher risk and potentially extremely beneficial treatments to those who clearly are going to go on to have more complications. Optimizing existing therapies. We know that, for instance, stem cell transplantation and hydroxyurea are underutilized. How can we actually use those better? Are any of these that can and should be combined? When we talk about new therapies, how will that relate to these existing therapies? Enhancing pain research, something that we think is very important. It's impossible for us to talk about really making headway if we're not thinking about improving access to care, quality of life, because this is certainly something that it makes no sense for us to advance science and not improve quality of life for patients, and then investing in research in sickle cell trait. I mentioned the Sickle Cell Disease Coalition, which we launched in September of last year. And ASH at no point in time ever thought that they would go it alone because, quite frankly, there have been many people in this field for quite some time. But we realized that there really were opportunities to unify and to, whenever possible, to speak collectively and to look at where our opportunities are to be more impactful as we work together. So the coalition was launched in September. Each time I presented this, the number of members continues to go up. It started out at 19, I think, on the day that we launched, and we're up to 45 members. It's a fairly broad coalition. It includes patient advocacy groups, our federal partners. It includes foundations. It also includes pharma, and we're thoroughly excited to have them at the table, and with a renewed interest in looking at where are the opportunities for interventions. We have a newsletter, we have calls with some frequency, and I think that what we want to continue to provide is a conduit for the sickle cell community broadly to identify opportunities for collaboration. This is just the launch. There's also apparently there are about 3 million impressions of using the hashtag Conquer Sickle Cell Disease to date. And so we really do think that we may have some traction, that this might be a conduit where perhaps all of us can find a way to look at being more collaborative, more comprehensive with our efforts. I want to share with you the current state of sickle cell, which we printed in limited editions at the time of the launch, but is now available online. And what we try to do is to summarize what we think is the current state, largely to allow us to use this as our beginning point to hopefully really accelerating the things that are being done. The focus was on access to care in the United States, training and professional education, research and clinical trials, but really importantly, global, because certainly we think that certainly that is not an insignificant part of our mission. And what we did is we created a report card, and there's a small number of them in the back of the room, and we specifically resisted giving them grades. It's not helpful to anyone to walk away having people sort of say, oh yeah, sickle cell got an F in everything, because quite frankly, there really are people that are doing things, but there is room for improvement. So this is on a scale of 10 when we took some of these ideas to a group of stakeholders. And these were patients, these were hematologists, these were other people who have an interest in sickle cell, and asked them to help us define what are the current limitations and where are our opportunities. How are we doing right now? And so, I'm certainly not going to go into great detail. Like I said, copies are in the back. But I think what it allows us to do is to sort of say, these are the areas that we think are most important. These are some of the ideas that we have and that hopefully the coalition will continue to work on to actually be impactful so that we move the needle up. Yes, in an ideal world, we'll get to a 10, but I think what we want to fundamentally see is progress. In terms of some of our current projects, I'll share with you what we're doing for access to care, research, and the global issues. In terms of access to care, this is a group that I've had the privilege of overseeing, and this is one that we really feel is extremely important because we've really taken on an educational strategy to try to develop and improve the knowledge, not just of hematologists, but of all healthcare providers about sickle cell disease. Certainly our first focus is within our own membership, but we recognize that there are many patients who are cared for by non-hematologists. We've also already begun creating patient-facing pocket guides. Some of the greatest demand for the pocket guides actually that we currently have are coming from patients, but arguably they are written for physicians or for medical staff, and so it's clear that there is a need for that. We want to continue in partnership with organizations, especially those who are boots on the ground, who in fact have a much stronger voice in the patient community as we move forward. And we're working with some of our agencies and insurers to look at innovative payment models for sickle cell disease care. Again, our first focus is internally with hematologists. We want to use CME, fellowship and residency training, every opportunity that we can, things on paper, things online. We are really open to using a variety of different modalities to look at educating a broader audience. From our point of view, we think every hematologist should be a resource in sickle cell disease, and this includes oncologists. There are many adult patients who many oncologists have 3 or 4 or 5 sickle cell patients in their practice. Or in a smaller hospital, they may be the only person on staff with this expertise, and they may be called by the emergency room. We want every single one of them to feel that they are prepared and that they have adequate information at hand to address at least the immediate needs of sickle cell patients. In terms of additional educational activities, we have already recruited patient advocate organizations to help us with developing patient-facing tools. The first one that we're working on right now is on hydroxyurea. We've also gotten a fair amount of enthusiasm from the national organizations that represent hospitalists. Hospitalists actually are physicians whose sole job is actually to take care of patients who are inpatients. And so that actually is a model that I suspect is here to stay, where you might have one doctor you see in the clinic, but a completely different physician who cares for you in the hospital. We are engaging them to find out ways to keep them well-informed and to make it easier for them to institute evidence-based guidelines by either doing practice guidelines for them, clinical pathways, and electronic order sets that allow them to actually cover all the things that are important for sickle cell care for the inpatients. We also want to engage primary care physicians because we know they're on the front line, and many times they are the sole provider for patients with sickle cell disease. In terms of research, ASH is exploring the development of a clinical trials network for sickle cell disease. This is a very ambitious undertaking, but I think one of the things that kept coming back when we were asking people what could ASH do in this sphere was the number one request was that we consider how we can support the creation of an infrastructure upon which organizations, whether they be federal, whether they be foundation, whether they be from pharmaceutical industry, to the extent that there are people who want to engage sickle cell providers and sickle cell patients to facilitate research. ASH is currently exploring how they can be helpful at creating the infrastructure to do that, and those conversations are ongoing. We also are exploring the development of a sickle cell disease consortium in sub-Saharan Africa. The primary focus there will be newborn screening and early intervention. We think that this is a must-do, and we've already had our initial meetings. We're meeting again this summer on the continent. We're looking forward to being as impactful as we can at taking advantage of our abilities as a convener to bring to, and then also to look at what resources make sense for us to support these individuals who are in country to come together to identify how they can work collectively to bring on newborn screening in Africa. There currently is not newborn screening nationally in any country in sub-Saharan Africa. And then to also look at the interventions that we now take for granted, penicillin prophylaxis, immunizations, and certainly in Africa, early malaria treatment that could easily save lives. We've also recognized that the guidelines that were put out by NHLBI had their limits. They were limitations that were noted the day that they were distributed. And so ASH has already initiated a new process for developing new sickle cell guidelines. And there are 5 panels, which will include patients on every single one of these panels. So from the outset, there will be the voice of the patient there, which was one of the criticisms of the NHLBI guidelines, is that patients were not involved in their development. We're hoping for publication of all of these at the beginning of 2019. ASH continues to be active on Capitol Hill. Our research priorities are still there, even notwithstanding with the change in administration. We think that there are still opportunities to enhance sickle cell activities at the federal level, both in research training and in the services that are provided to sickle cell disease. We think that there is also a role in legislation to improve reimbursement for sickle cell disease care, and we'll continue to interact with partners and friends on Capitol Hill, and hopefully to make even new friends on Capitol Hill to continue with that. So in summary, we have unprecedented opportunities to advance research and to provide high-quality medical care for patients with sickle cell disease. ASH is committed to its development of educational tools for healthcare providers, but also for patients, that will focus on evidence-based sickle cell care. We are looking forward to our new sickle cell guidelines that will cover both acute and chronic complications of sickle cell. ASH is intent on having a global impact through a consortium in Africa to institute newborn screening and early intervention. We will continue to work with Congress and our federal partners to enhance and expand federal sickle cell disease programs, but we absolutely know that without ongoing and in many instances increased investment, that the progress that we've made thus far will be lost. And we hope that you'll continue to join us and you'll check us out at the Sickle Cell Disease Coalition site. Thank you. So I'm not sure if we're breaking, if we're asking questions, or...
We have time for a few questions.
Great. I think one way in the back.
With respect to genetic biomarkers, hello?
Yeah.
With respect to...
I think it works now.
Can you hear me?
Yeah.
Okay. With respect to genetic biomarkers, with this population and any data collection around predetermined biomarkers, or is there any data that has any programs that you're aware of, any programs that are going on? And 2, If there are any programs that are going on, has there been any data to suggest that there's some variances in those biomarkers with respect to sickle cell patients? That's one. And then two, is there any gene therapy or any pharmacogenomics that are being developed around that consideration?
So I can say it's great that I can actually say yes and yes, which I can't, which was not always the case. So to your first question, there are small biorepositories, some of which were collected as part of NIH funding, and so it is now in the public domain. So there are some small biorepositories. They are not necessarily always linked with clinical information, and so sometimes there is a pellet of DNA or some cells in a tube over here, and you're learning a lot about sickle cell disease, but you may not necessarily know who those cells came from in terms of their profile. We think there are opportunities to continue to expand on those efforts and to find ways, while protecting confidentiality and patient identity, to be able to have some identifiers that allow you to actually look at the phenotype or the clinical manifestations of the individuals who actually provided those samples. So those very much are there. There already are some small efforts. So the most common one we've known for some time, for instance, is something called fetal hemoglobin. It's a hemoglobin that babies naturally make, but that all of us stop making. We're about 6 to 12 months of age, which is unfortunately exactly when children with sickle cell disease start having problems. It's in part because that fetal globin goes down. We know that hydroxyurea, among many things, makes that go back up. But there are now molecular approaches. It's not just something like hydroxyurea, but there actually are now targeted efforts to actually, for instance, induce fetal hemoglobin to turn back on, some of which are incredibly promising. Gene therapy, Dr. Cantor is in the audience, and really she is the person who should be talking about gene therapy as one of the leads in that. I certainly have the privilege of being one of the investigators on one of the gene therapy trials. I think all of us are incredibly excited about the possibility of cure. Transplantation currently exists. It's underutilized. There have been maybe 1,000 transplants done worldwide. Clearly, this is a modality that has been proven over the last 20 years to be effective. There's lots of reasons why there has been limited uptake. The best results have been with sibling donors, but many sickle cell patients will not have a perfectly matched sibling donor. Gene therapy, the patient is their own donor, and so in theory, both gene therapy and gene editing are quite promising. The question will often be, with those kinds of interventions, we talk about those things in countries, in our country, where we have access to medical centers that have the kinds of resources to support someone through that. But what about small molecules? What about oral medications that could conceivably be used in smaller cities, in rural communities, and in less developed countries? We think that all of these are important to look at. And as we learn more about severity markers, we'll decide, for instance, if this is a patient whose profile looks like one that you're likely to live to 65 with no problems, we're going to say, God bless you, stay in care, but you're going to be fine. On the other hand, if we can see a genetic profile of someone and predict someone who is going to have a stroke, who is going to have repeated acute chest, who is going to die when they are 24, that is someone that we might talk to them about something that potentially is higher risk, but hopefully higher benefit given their profile. We think that this is not just conceptual. We think this could actually really happen. What we want to be able to do is get investigators who are working on these kinds of things closer to access to the communities that are most impacted by this. But while we're developing these things, we need buy-in from the community that's affected. It makes no sense for us to develop these things if these are things that this community does not want. And so we think that there's an opportunity to really make sure that as we're moving forward together. Yes?
A much more boring question, but could you tell me a little bit of, Dr. Thompson, the work that you ASH is doing with NHLBI. You mentioned the treatment guidelines that
Yes.
you're working on. I know
Yes.
NHLBI has some, so that we don't end up with two separate guidelines or, competing guidelines.
So and certainly I will talk specifically about the guidelines, and I can tell you about some other things that we're doing. The guidelines issue is NHLBI made it very clear that they don't intend it, they would just as soon not continue to promulgate guidelines. So we can tell you with absolute certainty there will not be a revision of the NHLBI guidelines. And so it was really with their awareness and blessing that ASH actually took on promulgating the existing guidelines, but certainly independently, we agree that they needed to be expanded and updated. So we agree completely. There is not benefit to the community to have redundancy, especially if it creates confusion. So that certainly is the NHLBI guidelines. There will not be another one, and so we're hoping, though, that the ASH guidelines will replace them. Similarly, for sickle cell trait, we also recognize that there's quite a bit of information, misinformation, information, whatever you want to call it, out in the community. And so that was why the CDC, the Sickle Cell Disease Association of America, and ASH got together to collectively say, can we actually agree on a set of materials that would be available, they're primarily on the CDC's website, that we believe represent the best science. Now, having said that, information and science in sickle cell trait is coming out quite quickly right now, and so there is an opportunity, though, when something is already on the web for us to update as we need to. But we agree that that having multiple organizations attempting to do the same thing at the same time is not desirable. ASH continues to have ongoing conversations with NHLBI as well as the rest of its federal partners. We don't believe that we should be doing anything that's already effectively being done by someone else. We also recognize that there's a role as a nonprofit to be impactful in ways that a federal partner cannot. So, for instance, when I go to Capitol Hill, even if I was just talking to someone that's a federal employee, they, of course, can't come with me, or they can come with, but, it's really very difficult for them to actually advocate in the way we would in talking to a member of Congress. So we recognize that we, I think, have complementary roles. But I think I couldn't agree with you more that we really absolutely want to avoid redundancy.
We do need to transition to the next.
Thank you.